special thanks to the Kazancıoğlu University Department of Conservatory and to Professor Saleh. Well, now I end my speech here. Thank you all for your patience, and I'm so proud to be a part of this congress and meeting you as being guests. And now, in a couple of minutes, we will start the Sanskrit program. Thank you.
Dr. Kazancıoğlu, Dr. Stefanidis, ladies, I'm sorry I could not be with you today to make this presentation personally, but I'm grateful to the Congress Chair, Dr. Ayşe for allowing me to make this.
Good morning to you all. Let me first introduce to you the very well-known Professor Garabed Eknoyan. He is a distinguished emeritus professor of medicine from Baylor College of Medicine in Houston, Texas, and he's also the past president of the National Kidney Foundation, DOKI, KDIGO, and he has served as the chair of steering committee of multi-center hemo study and many studies that has been funded by NIH. And also, he is the founding member and the past president of the International Association for the History of Nephrology. Professor Eknoyan has received his medical degree from the American University of Beirut and served his residency at Baylor University Medical Center in Dallas, Texas, and Boston City Hospital in Boston, Massachusetts. And he was doing his postdoctoral research fellowship in kidney and electrode metabolism at the University of Texas. He served on the faculty of Baylor College of Medicine from 1968 to 2020 when he resigned. And now he has authored many articles and books which we used as our textbooks, and we looked up to him for his great work. For his many services to the National Kidney Foundation, the foundation established in 2002 the Garabed Eknoyan Award granted yearly at its annual meeting to a nephrology leader who has best served in improving the outcomes of patients with chronic kidney diseases. For his years of training fellows in nephrology, Baylor College of Medicine also established in 2011 the Garabed Eknoyan Endowed Annual Lecture in Nephrology from donations made by his past fellows and colleagues. And also to his services to the care of kidney diseases, the American Society of Nephrology has established the annual Garabed Eknoyan Endowed Lectureship in 2021. And for his teaching years at Baylor College of Medicine, the college also established the Garabed Eknoyan Endowed Nephrology Professorships. I think these are not able to fulfill what he has done for the care of our patient population and for the future generation of nephrologists, and we leave the floor to him.
I'm very proud to be here today to be a president of this speech, of this valuable speech, together with Professor Kazancıoğlu. Thank you very much. Dear Professor Eknoyan, I'm very happy to hear your voice today and to see you, although you're not with us. It's a pity that it wouldn't be made possible to have you with us today. And me and all our colleagues here are very eager to hear your speech on interstitial nephritis. Thank you very much, you, for your valuable help to our society. As a founding member, we love you and are all eager to hear your speech on interstitial nephritis, history and future. Thank you very much.
Stefanidis, ladies and gentlemen. I'm sorry I could not be with you today to make this presentation personally, but I'm grateful to the Congress Chair, Dr. Garabed, for allowing me to make this video presentation of my talk. The inclusive title of my presentation, notwithstanding, what I'm going to talk about mostly is about interstitial nephritis, Wherefrom. I'll touch on Wherein a little bit, but Whereto is in the future and does not belong in a historical presentation. The outline of my presentation will begin by laying the background of kidney structure and function, kidney disease, entry of the term nephritis, the concept of interstitial nephritis, fibrosis, and finally something about interstitial nephritis that became a disease before I conclude my talk. Beginning with kidney structure and function. It is useful to remember what Homer Smith, a founding father of nephrology, in his text erudite book From Fish the Philosopher, exposed. Namely, the kidney began as a tubule. It is millions of years later, particularly during the Devonian period, that as animals became predatory and developed teeth and started migrating and eating more protein, that the glomerular capillaries emerged, the glomerulus formed for the excretion of urea by filtration. With this in mind then, kidney function as it evolved began with the Egyptians who believed that circulation and the heart were at the center of everything, and that by some magic within the blood, urine was formed, shown in yellow, or emptied in the bladder. This concept was modified and expanded on by Galen, who now perceived as the circulation as a to and fro, back and forth flow of blood, including that of blood coming to the liver where blood is formed, whereby the blood goes to the kidney, which gets rid of excess fluidities and returns it to the liver for formation of blood. And it is thus that by the end of the 1st century, the function and structure of the kidney was conceived as an undifferentiated parenchymatous organ as defined by Erasmus, with attractive powers that serve the nutrition, the needs of the body in eliminating excess fluidities. And so, by the end of that period, and what prevailed is what Aristotle pronounced, that the kidneys are not present of necessity. And this general concept prevailed until the scientific revolution. when first Harvey described the circulation and therefore eliminated Gallen's concept of back and forth flow of blood, while Bellini described the tubules, and shortly after that Marpighi the corpuscles, and therefore eliminating the non-structural composition of the kidney. And within the next 2 centuries, in the 19th century, when Bowman described the connection of the glomerulus to the tubules, Ludwig described the physical forces necessary for glomerular filtration, and Bernard, who introduced the concept of the milieu intérieur. And it is thus that by the end of the 19th century, the kidney was conceived still as a parenchymatous but not tubular organ as defined by Bellini, with filtering powers as defined by Bowman and Ludwig, that serves the homeostatic needs of the body as defined by Bowman. It is within these structural and functional concepts that in the 19th century the concept of kidney disease also was introduced. As it began, though, kidney function was perceived as one of stones that caused pain, and urine output that was reflected as too much urine as in diabetes, and too little urine as in acute renal failure. And this concept of kidney function as that of urine and stones generally prevailed the understanding of kidney disease until the 19th century. And when Richard Bright, in his report of medical cases, reported what came to be known as Bright's disease. Now then, Bright just described the general morphology of the kidney, with very little, a few words only on the ultrastructure. The ultrastructure of the kidney developed in the next 30 years when the microscope began to be used and emphasized what Prague had alluded to, which is the acute and chronic forms of Bright's disease. And then in 1950, 100 years later, when the kidney biopsy was introduced and led to the further definition of the structure of the kidney and the emergence of nephrology, with the beginning of the International Society of Nephrology in 1961 and our own organization in 1994. And so it was within the evolution of our understanding of Bright's disease that the interstitial nephritis would emerge. As I mentioned, Richard Bright reported only the gross features of the kidney, that of big red kidney, big white kidney, and a small shrunken kidney of end-stage kidney disease. The term nephritis is an old term dating back to the 16th century. And although Richard Bright uses the term nephritis, it was Rudolf Virchow that really entered the term nephritis into the language of nephrology when he described the large white kidney as parenchymatous or tubular nephritis, and interstitial nephritis for the red granular kidney, while he attributed vascular disease to amyloidosis. And it is thus that the term nephritis entered and was popularized in the language of medicine, thanks to the Rudolf Virchow, who in his iconic text, Cellular Pathology, talked about parenchymatous nephritis and interstitial nephritis. And it is to the students of Rudolf Virchow that we owe much of what happened subsequently for the ultrastructural changes of the kidney. Beginning with Axel Key, who described the mesangial and epithelial cells of the glomerulus, and Edwin Krebs, who described glomerulonephritis, or essentially inflammation of the glomeruli, that came to be classified as Krebs disease until the past 20 years as used in the ICD-9 classification before the advent of ACI that we use nowadays. And so it was by the end of the 19th century that interstitial nephritis was replaced by glomerular nephritis by Clifford Albert in his classification, where he still used parenchymatous nephritis, but also began to talk about the changes of interstitial lesion due to hypertension. And so by the beginning of the 20th century, at the beginning of the First World War, Farr and Walhart classified kidney as nephrosis instead of parenchymatous nephritis, continued to use glomerular nephritis, and now also introduced the term sclerosis for vascular lesions. Now the term of nephrosis that Farr and Walhart used had been introduced in 1905 by a non-nephrologist called Mueller for the non-inflammatory degenerative changes of the disease of the tubules, where the tubules are so large that they replace most of the parenchyma of the kidney, and hence the term nephrosis. And so, by the end of World War I, with the entry of glomerulonephritis and nephrosis, the term Crohn's disease exited, was replaced by nephritis in its acute and chronic forms, and by the 1960s, as morphology began to be studied more carefully, particularly by the use of biopsy needle entry of the concept of interstitial fibrosis. Now, William Bowman, in his description of the glomerular tubular junction, did mention a sort of matrix in which the convoluted tubules and vessels are embedded in, but never expanded on them. This notion of the matrix was really began to be appreciated during that period in the 1840s and thereafter, by one of the junior colleagues of Richard Price, George Johnson, who is one who really promoted the concept of acute and chronic glomerulonephritis, in which he did allude to the interstitial changes in acute form and the fibrous tissue that develops in the chronic form. And his argument was based on the urine sediment that of the appearance of epithelial cells in the acute form of the disease, and hence the importance of the tubular interstitial lesion, and the appearance of highly large granular cast in the chronic form of the disease. And it is within this context of the evolving of kidney disease and interstitial changes that also the fibrous cells of the interstitial began to be described in 1851. But the importance of the interstitial changes was described by another student of Rudolf Virchow, Arnold Beer, who in 1859 published a text on the connective substance of the human kidney, both in normal and disease condition, in which he talked about the acute and chronic changes and emphasized the importance of interstitial kidney affection, and therefore the entry on the greater appreciation of the lesion that was described as interstitial nephritis by a Scottish physician by the name of Brian Waller, who in his thesis of graduation from Edinburgh University classified the interstitial lesion as one of mononuclear cell infiltration that in the course of progression of the disease undergoes transformation into fibrous metamorphosis. Brian Waller is better known in literature as the sponsor and mentor of Arthur Conan Doyle, who also graduated from Edinburgh University and was the author of the series of articles began in 1887 about Sherlock Holmes. The character of Sherlock Holmes that he developed was to some extent based on the diagnostic abilities and the acuity of observation of Brian Waller that defined. But I digress. To go back to the entry and evolution of interstitial nephritis. Here again, we owe it to a student of Rudolf Virchow, Anton Werner, who in 1860 described an unusual case of scarlet fever in which the glomeruli were spared and the interstitium was infiltrated by mononuclear cells that came to be termed acute lymphomatous nephritis. And it is to the credit of William Councilman, but beginning with an interest in glomerular lesion, that in 1897 he described the interstitial changes of glomerulonephritis as edematous and, in some cases, the appearance of interstitial cellular infection in the absence of glomeruli that he called acute interstitial nephritis. And it is on the basis of this then that the following year he published his now famous article titled Acute Interstitial Nephritis, that introduced the concept of acute interstitial nephritis as a clinical entity due to infiltration by inflammatory cells, mononuclear inflammatory cells, in the cortex and the cortical medullary junction while sparing the glomeruli. And in the 42 cases that he described, they were all due to infections. But it is important to note here that he also included a case of acute glomerulonephritis, and some of these cases in Paima and lobar pneumonia may well have been acute tubular necrosis as well as acute interstitial nephritis. But it is thus that by the end of the 19th century, the term acute interstitial nephritis entered the medical parlance, but sort of remained dormant until the 20th century with the advent of kidney biopsy and refinements in microscopy. And it was during World War II, within the expanding notion of acute renal failure and the entry of dialysis for its treatment, that the term interstitial nephritis re-entered nephrology from biopsy studies of cases of acute interstitial nephritis due to drug sensitivity, due to phenylenedione and penicillin reported in the 1960s. And so the renaissance of acute interstitial nephritis was to a great extent due to the advent of interest in acute renal failure and treatment with hemodialysis, as well as the entry of antibiotics that became a leading cause of drugs hypersensitivity and acute renal failure, and hence the changing profile of acute interstitial nephritis to a great extent due to drugs that popularized the term acute interstitial nephritis. And this is the number of articles on acute interstitial nephritis as that appear in PubMed. And as you can see, although recognized, there were very few articles until the mid-60s when the biopsy became more prevalent and antibiotics began to be used, that interest and publications increased to its present form. And it is during this course of events that also the primary form of chronic interstitial nephritis was recognized. From biopsy studies on analgesic nephropathy, vesico-urethral reflux, and backup nephropathy in the 1950s and the 1960s. And so the concept of interstitial disease expanded and led to the entrance of the term tubulo-interstitial nephritis because of the importance of the tubules both as being injured in acute interstitial nephritis, as tubular dysfunction being the first manifestation before the drop in GFR, and because of the dominance of tubular lesions that develop in the course of death. The term was introduced in 1963 as tubulointerstitial nephropathy in a chronic form of idiopathic renal failure in children, and prevailed as chronic interstitial nephritis and as well as chronic interstitial nephritis, with an increasing use of chronic tubular interstitial nephritis as the importance of tubular function was being appreciated. But in contrast, the acute form of the disease continues to be preferentially termed acute interstitial nephritis, and only in a few instances as tubular interstitial nephritis, to the credit of its first description by Kazancıoğlu. And it is thus that by the 1970s, the role of interstitial nephritis as a secondary disease that develops into glomerular disease but contributes to its progression was described when morphologic studies revealed a closer correlation of interstitial changes to inguinal clearance than did glomerular changes as studied by morphology. And so the term interstitial nephritis in an acute form, in its chronic primary and secondary forms, now dominate the medical literature. So to conclude, I have shared with you a 400-year odyssey of the interstitial nephritis, first as a component of chronic renal failure as described by Richard Bright, its emergence at the closing of the 19th century as acute interstitial nephritis, a separate disease, and in the 1950s again, the primary forms of the chronic disease in analgesic nephropathy, vesicular reflux, and vasovagal nephropathy, the importance of acute renal failure and its treatment in emphasizing the role of acute interstitial nephritis, whose secondary forms have been increasingly recognized, and then the ultimate classification of both acute tubular necrosis and acute interstitial nephritis as acute kidney injury in the past decade. As far as the terminology, what began as interstitial nephritis became a disease that was classified as tubular interstitial nephritis that we use now. And it is within this period that Aristotle's original term, although wrong in its initial statement, proved the correct conclusion that he had, but had the function of perfecting the animal itself. Thank you very much for your attention. I'm sorry I could not be with you, and I wish you a successful Congress. If you have any questions, please email me at bcm.edu. I promise to answer them gladly and promptly.
Thank you for your presentation. And thank you that you brought us through the history of interstitial nephritis and kidney in general. We are with all thank you and wish you to see in the next Congress or in the near future in personal contact. I give the microphone to my colleague to end the session.
Thank you very much indeed, and we're hoping to host you in the coming congresses soon, and we will move to the next session. Thank you for participating.